Yeah, hello, this is Peter Roux, a neurosurgeon from Philadelphia in the United States. We're talking about telemedicine for consultation. And one thing that the COVID pandemic has demonstrated is how we can modify care using new telecommunications. It's important to recognize what telehealth and telemedicine are. It's slightly different. Telehealth is the use of electronic information and telecommunication technologies to extend care. It can be synchronous or asynchronous. Telemedicine, on the other hand, is a very distinct service that seeks to improve outcome by permitting real-time interactive communication between the patient and the physician. And what I'm going to talk about in this presentation is really between physician and physician. This is a definition that comes from the Centers for Medicare and Medicaid Services. In the United States, that is what drives all revenue and billing by insurance companies. So this definition is the best definition, at least in the US, for telemedicine. I have no conflicts in this discussion, and I'm going to try and focus on how telemedicine can be used in a specialty such as neurosurgery, which might be surprising since you have to have a surgeon on site, obviously, to do surgery, although there certainly are robotic opportunities that allow us to do even remote surgery. Well, does it fit in with the rights to health as defined by the United Nations Health Commissioner? And yes, it does, because these are the 5 basic rights: accessibility, availability, participation, accountability, acceptability, and quality. We have to understand neurosurgical emergencies. It's only about 7% of patients who are admitted urgently to hospital that have surgery within 2 days of admission. These patients often do worse, not surprisingly, because of the emergency nature. Many patients who require admission and consultation do not necessarily undergo surgical intervention, perhaps best exemplified in mild traumatic brain injury, where less than 1% of patients do. One can often predict that based on their coma scale, age, or the use of anticoagulants. There are very distinct guidelines that exist from ATLS that suggest when patients should be transferred to a higher level of care. Whatever we do requires communication. And communication is a mutual exchange of information between 2 or more individuals. It's a dynamic, continuous transfer of process. There are ways of improving communication. And in essence, it's not about adding more, but removing barriers to effective communication. So it's clear and direct requests, closed loop communications, effective delegation of tasks, appropriate communication of the urgency of a patient problem, prioritizing care, and sharing that information so that all members of a team taking care of patients are comfortable with their tasks. It's important to do this well from the beginning, because where you lose information in one phase of care can compromise patient safety in subsequent cares. As a consultant, brevity is best. I don't need a lot of information to be able to make a decision about appropriate patient care. And this is an example of brevity. So a college class was right to ask a very short essay using as few words as possible, but it had to include the following: religion, sex, and mystery. That's the winner. Good God, I'm pregnant. I wonder who did it. So in essence, when I, as a surgeon, am consulted about a patient with brain injury, I don't need a lot of information. With the electronic medical record and PACS, I can gather a lot of information from imaging. And that is perhaps one of the advantages of something like neurosurgery in a telemedicine world, because it is very visually dependent, i.e. the imaging. Why telemedicine? Well, there is a shortage of neurosurgeons. There's a global shortage of neurosurgeons. There's one neurosurgeon for more than 6 million people in sub-Saharan Africa. In the United States, it's one for 65,000 citizens. You can see that great disparity. But even in the United States, there's this paucity in certain areas because there are far fewer neurosurgeons than there are actually hospitals. And most neurosurgical services tend to cluster in areas of greater population density, whereas about 20% of the population is in a rural area. So it's estimated that worldwide another 23,000 neurosurgeons are needed to meet global needs. Now, there's also a shortage of physicians in the United States, and it's estimated in about 10 years there will be 130 more physicians needed to cover all aspects of medical care. Telemedicine can start to address those shortages. There are other means: mobile neurosurgical units. You can look at the Flying Doctor in Australia, rapid training programs and core ethods, or the use of acute care and trauma surgeons. But there's distinct potential advantages of telemedicine. You can get immediate patient access. You can overcome service gaps. There's clinical support. Patients are satisfied. We've been using telemedicine for a long time, long before COVID became part of the equation, and patients are generally satisfied. They think it's pretty cool to be talking to somebody through a robot, if you wish. And it allows patients to be appropriately triaged to hospitals where appropriate care can be given. This reduces cost, and there's a significant cost and benefit. There's rather a significant cost when there's inappropriate transfer. It's estimated that in the United States, if telemedicine is used efficiently and can eliminate just 1% of emergency department visits, it's more than $100 million a year in healthcare costs that are saved. There are also cost savings for a patient. In the United States, most patients spend over 2 hours in a patient or in a physician visit, but there's only 20 minutes of physician time. Some of that has to do with travel time. You can eliminate that. I can also think of the greenhouse effect. You can eliminate carbon emissions by not having patients drive to their care. Are patients satisfied? The answer is yes. This is an orthopedic follow-up, and perhaps orthopedic follow-up might be akin to neurosurgical follow-up. These are studies, and as you can see, most of them are small sample sizes, but the vast majority of patients, more than 90%, are satisfied, and very few patients, about 10%, actually need a physical follow-up because not enough information occurs in the telemedicine visit. There are barriers to use. Most of those have to do with licensing, credentialing, and liability. Provider remuneration and billing were an issue, but now these have been addressed partly because of the COVID pandemic by Medicare and state bodies in the United States. There is barriers that occur because physicians sometimes are resistant to change. There are very few technological issues that affect it. There's been a rapid growth. There's been a rapid growth in large part because of the advances in computer technology and telecommunications. You think about what a cell phone was like 20 years ago, it could dial a number, and that was it. If you put it in your pocket and left the store, you'd be arrested for shoplifting because the cell phone was so big. Now with a smartphone, you can do pretty much anything. I don't think my children even use a computer anymore because the cell phone is so damn good at what it can do. There are a large number of studies that have demonstrated the feasibility, the satisfaction from the patient and the provider, and at least similar outcomes in many fields, particularly critical care, stroke, emergency medicine, burn care, and even in chronic care in nursing homes. And there has been growth. That growth has occurred rapidly even before COVID, but since COVID, there's been an even greater exponential growth. More than 50% of billing charges for primary care visits in April of this year were through telemedicine visits in the United States. Perhaps one of the best examples of the efficacy of telemedicine has been in stroke care. Here's the inside of a mobile stroke unit. So an EMS physician has gone to pick up the patient, and the communication occurs through a PACS system and telestroke to a remote surgeon or a remote neurologist. And in these studies, and this is a systematic review that was performed recently, we see that the number of patients who receive IV TPA is increased. The number of patients who are treated within 3 hours are increased. Mortality is reduced without there necessarily being an increase in intracerebral hemorrhage. Before COVID, telemedicine was used in the United States by about 15% of physicians for patient interactions. Radiologists, psychiatrists, and cardiologists had the highest use. There were no surgical specialties in the top 10 users, but this is starting to change. Fewer physicians use it in direct interactions with other healthcare professionals. Perhaps those who used it most frequently were ER physicians. And this is a study that came from ERs in New England, so the northeast of the United States. And as you can see, most of this was for teleneurology and telestroke. In neurosurgery, we like technology. Here's a slide of about 25 years ago when I was working with a device called RAMS for robot-assisted microsurgery. We have robots to do stereotactic biopsies. Robots are used for telemonitoring, so a remote surgeon can intervene and help and direct care. But can it be used in neurosurgery? And the answer is yes. There have been a variety of studies that have come from places like India and Egypt, Albania, and so forth that have demonstrated it's feasible to do in clinic consultation. When the COVID pandemic started in our environment, we basically shut down in-person visits. About 90% of what we do now in outpatient consultation is through a remote video tele visit. It can be used in post-operative care and monitoring, and it can be also effectively used to triage patients appropriately with trauma, stroke, and intracerebral hemorrhage. Why is this important? Well, transfer of patients is not without risk. Neurologic decline can be seen, diagnostic error is not infrequent, and there often is a delay. This is a study that looked at transfer of patients in the United States, where the mean time to transfer was more than 5 hours, even though the distance of transfer was 30 minutes. Most of this was because of a lack of ICU beds at the receiving hospital, and hence, appropriate transfer not only helps the patient, but it also can improve resource utilization at the receiving institution. It's amazing how many transfers are inappropriate, or what's called secondary over triage. This is commonly seen in pediatric traumatic brain injury, about 40%, even as something that seems fundamentally simple, Corder-Aquinas syndrome. This is a study where all patients with Corder-Aquinas syndrome were audited in England, and only 15% of those patients who were transferred actually had surgery. In orthopedics, a large number of patients who are sent from a lower level trauma center to a high level trauma center are often sent home from the emergency room. So we embraced teleneurosurgery several years ago in Bassett healthcare system. Now, this is a healthcare system that exists up in rural central New York. Here's the healthcare system. It's in Cooperstown. If anybody knows anything about baseball, that's a mecca for the Hall of Fame. Here's the system that exists. We use telemedicine, and I'm going to explain some of the experience before COVID. So it's not a system that, or not a service that's available every single day, because they are neurosurgeons who are physically there. It's when they're not available. So it's probably about 50% of the time it's used. So in a 1-year period, which really represents probably about 20 to 30 weeks of care, 223 consults were through the telemedicine service. The demographics reflect the rural area and the population. Most of the transfers or the consults came through emergency medicine. Here are the various diagnoses, and you can see of all types. The triage, what's important is up to 60% remained within the system, 20% were able to go home, and only 8% were transferred to a higher level of care or another system. Some patients that remained ultimately had surgery by a surgeon who was then present a few days later. The outcomes were inevitably very good. The opinion of teleneurosurgery improved over time. When it started, people didn't have a favorable view of it. With time, most people think of it favorably or very favorably. Most think it's easy to use. And this is what the future is going to hold. Here's a robot serving beer in a bar in Amsterdam. We use robotics in the ICU. This is Paul Vesper with his telerobot. It's revolutionized ICU care. The screen allows you to see all the information you need about a patient. People ask, well, where should you do neurosurgery? Since residency work hour restrictions and various studies have demonstrated outcomes are actually worse in academic centers. Time to surgery might be important, but paradoxically, time has less of an effect than the basic underlying pathophysiology. So the sicker the patient, the worse they do, rather than the time to surgery, although in select patients, time is very important. And this is true also in spinal cord injury. Outcome often is affected by other factors rather than the timing of surgery or intervention. So, in conclusion, it's feasible. It does improve patient access to care. It requires a strong collaborative effort and efficient, seamless communication. So if you're going to set something up, it's a hub and spoke model with standard operating procedures between the various spokes and hubs, multidisciplinary and multi and cross-institutional collaboration and communication. Not surprisingly, we're now going to see a randomized trial that looks at the use of telemedicine in acute neurology. Important to remember, though, as Lars Lexell, a very famous neurosurgeon, said, "A fool with a tool is still a fool." Thank you.